welcome to today's episode of Myeloma Crowd Radio, formerly Inpatient Myeloma Radio, a show that connects patients with myeloma researchers. You can find all past and future shows on myelomacrowd.org, and if you'd like to receive a weekly email about past and upcoming interviews, as well as weekly articles on the Myeloma Crowd, you can subscribe to our newsletter on the homepage, or you can follow us there on Facebook or Twitter. Now, we're excited to announce that we've officially launched our Myeloma Crowd Research Initiative for high-risk myeloma, and investigators are submitting proposals throughout the month of February. We have an expert team of myeloma specialists on our scientific advisory board that will help validate and select the projects. But for the first time, a group of myeloma patients will be involved in making the final selection of projects that we believe together are the most promising. We chose high-risk myeloma because today's options don't give extended life expectancy like they do for standard risk patients, and we think that if we can find solutions for the most aggressive types of myeloma, it will help even standard or low-risk myeloma patients, and we think it's time for a new way of funding research and finding creative solutions for the disease. Now, on today's show, we are delighted to have Dr. Ajay Nooka of the Emory Winship Cancer Institute with us today to talk about smoldering myeloma and the newer approaches to stop myeloma before it gets started. So, Dr. Nooka, welcome to the program.
Thank you very much, Jennifer. I'm really honored to be on your show and speak to the myeloma patients. I probably will start with my perspective on the magnitude of the problem of smoldering myeloma in the United States.
Okay. Well, before you do that, let me give a quick introduction for you, just so people know who you are and what you work on. Dr. Ajay Nooka is Assistant Professor of Hematology and Medical Oncology at Emory University School of Medicine and is part of the hematology care team at the Winship Cancer Institute of Emory University. Dr. Nooka attended medical school at the Andhra Medical College in India. He earned his master's degree in public health at University of Texas School of Public Health, and then he went on to complete his residency in Canton, Ohio. He did a fellowship at Winship at Emory, and his research interests include integrating genomic and clinical data on a uniform platform to interpret in a meaningful way to risk stratify myeloma patients and evaluate newer therapies aimed at prolonging survival. He serves on the editorial board for the American Journal of Clinical Oncology, the Journal of Hematological Malignancies, Lymphoma and Chronic Lymphocytic Leukemias, and is an ad hoc reviewer for the Annals of Oncology, Cancer Oncology, Leukemia Research, Bone Marrow Transplantation, the Biology of Blood and Marrow Transplantation, the European Journal of Cancer, Current Oncology, and the Indian Journal of Medical Research. He is also the recipient of many awards, including awards from the MMRF, the IMF, ASCO, the Fellowship of American College of Physicians, the Frederick Whittier Excellence in Research Award in Canton, and the Rockford Scholarship, in addition to many more that I can't even name. So, Dr. Nooka, thank you so much for joining us today, and please go ahead with what you wanted to start out with in smoldering myeloma.
Thanks very much, Jennifer. So, I'd like to take some time about what we're dealing with in terms of the magnitude of the problem in the United States. So I'd like to start with simple numbers. So if you take multiple myeloma, which is the second most common hematological malignancy, it accounts for probably 25,000 new cases per year in the United States. Now, let's take the prevalence of smoldering myeloma. So I think we'll start with a small math. Take the U.S. population today, which is approximately 300 million. And if you see who are the patients who are more common to have smoldering multiple myeloma or any plasma cell dyscrasia, it's about the age of 65. So 15% of the population are about the age of 65, which makes it 15% of 300 million, which is 45 million people that are aged more than 65. So among these people, it's not uncommon to see the presence of a monoclonal protein in approximately 5%. So 5% of 45 million people gives approximately 2.5 million people. So if you take these 2.5 million people by the most conservative estimate if 15% of these patients have smoldering multiple myeloma, it makes around 400,000 patients with smoldering multiple myeloma, yet only 25,000 new cases of myeloma are diagnosed every year.
Wow, so people just don't know.
Exactly. So it's very essential to risk stratify these smoldering myeloma patients and to identify those who are at a high risk for transformation and focus on this group, aiming at preventing the disease progression to symptomatic myeloma. That will be the best way to gain the best outcomes. So the simple definitions of smoldering myeloma and symptomatic myeloma are essential to understand for better clarity. So basically, the defining criteria for symptomatic myeloma are exhibition of an end organ damage as defined by the CRAB criteria. The mnemonic CRAB criteria stands for high calcium levels, renal failure, anemia, or bone lesions. These are, as a resultant of the clonal expansion, would be called as symptomatic myeloma. In the absence of any of these CRAB criteria, patients presenting with a monoclonal protein due to a clonal process are defined to have either an MGUS, which is monoclonal gammopathy of undetermined significance, or smoldering multiple myeloma. The differentiation is basically based on the disease burden. So if smoldering multiple myeloma is defined as a serum M spike of greater than or equal to 3 gram per deciliter, or greater than or equal to 10% monoclonal plasma cells in the bone marrow biopsy, or both. So, coming to the definition of MGUS, it is defined as having no CRAB criteria and less than 10% plasma cells in the marrow and less than 3 grams per deciliter of M protein. So, historically and even today, both these precursor conditions are managed by the wait and watch approach. So the good thing, which is very encouraging, is that in the recent days, there has been a push towards treating certain groups of the smoldering myeloma patients even without the presence of the CRAB criteria. So, and these changes are reflected mostly in the recent changes by the definition from the International Myeloma Working Group. This is very welcoming for smoldering myeloma patients. So the new definition of smoldering myeloma includes any patient with a bone marrow plasma cells of 10 to 60%, or M spike of greater than or equal to 3 gram per deciliter, or urine protein equal to greater than half gram of protein over a 24-hour period. So, which of course changes the definition of symptomatic myeloma. So now the new definition of symptomatic myeloma, in the absence of CRAB criteria, include patients with bone marrow plasma cells of greater than 60% or equal to 60%, serum free light chain ratio of greater than or equal to 100, or presence of more than one focal lesion on the MRI. So a few words on the biology. Why does this happen? So the transformation from a monoclonal gammopathy of undetermined significance to myeloma, in my opinion, is a disease continuum process. So it starts with an MGUS, proceeds to smoldering multiple myeloma, proceeds to symptomatic multiple myeloma. There are certain genetic events, these are called initiating events, that lead to transformation of a plasma cell to a malignant cell by acquiring certain chromosomal abnormalities. These typically involve the IGH locus of chromosome 14. So these are present on all the clones. Like whenever there is this transformation, these are present in all these changes that are seen are present on all the clones. But
yes, I asked one doctor if you could kill it somehow in a set of clones. He said, no, they're on every single cell.
Yeah, that's true. So the subsequent hits, the other transformations happen on only a certain sets of clones that basically they're more evolved, they have high proliferation rate. These are the ones where the secondary chromosomal changes happen, and which typically have a proliferative advantage and have the potential to cause the progression of the disease. So a few examples of such changes are point mutations of the NRAS or KRAS or MIC upregulations. All these things can cause these second hits, and these also correlate with the disease progression.
Can I ask you a quick question about that? I know
Sure.
that you're testing with the fish and sometimes the GEP, and I know you said you were doing RNA sequencing that's finding some of these translocations. What test do you use to test for the NRAS and the KRAS?
So right now it's more from we don't use the GEP at this point, but it's more of a looking at the RNA sequencing to look for any of these mutations.
Okay. Okay, sorry to interrupt you.
Not a problem. I'll go with how I typically diagnose, typically what my overall strategy for a smoldering clinical trial, a smoldering myeloma patient is. Initially, I think the first thing is to establish the diagnosis. So in a smoldering myeloma patient, so what I typically do is to proceed with a baseline bone marrow exam, get a skeletal survey, and I'll have a very less threshold to obtain a MRI of the spine and the pelvis, because there can be occult lesions that can be seen that would change the whole diagnosis. I would have less threshold to obtain a PET CT if that is needed, if I have higher suspicion for any PET-avid lesions. So there have been multiple trials before that had shown that any identification of any of these lesions by these imaging techniques can predict for a more rapid progression to multiple myeloma. So once the diagnosis is made, what's the next step? Like, the next step is to go with a risk stratification. As we just talked about, all these numbers of around 300 to 400,000 smoldering myeloma patients, and among them, only a certain subset of them transform to symptomatic myeloma very rapidly. And how do you identify these patients? That's typically based on the available risk stratifications. So,
and those are really clinical presentations, right? I mean, it's not like you're looking at, do you have certain translocations or gene deletions? You're looking at what you're seeing on the lab results.
So typically these are based on the lab results. So I'll speak in a bit about the role of any of these cytogenetic abnormalities like translocation 414s with smoldering. Should they be treated or not?
Okay.
I strongly encourage my patients to go on to clinical trials when they're exhibiting any of these abnormalities, any of these new chromosomal abnormalities, including the translocations. So in terms of the risk stratification based on the clinical parameters, there are only two more commonly accepted ones. One is the Spanish risk stratification, which is called it's the PETIMA risk stratification, and the other one is the Mayo Clinic risk stratification. So the more accepted one in the United States is the Mayo Clinic risk stratification, which typically takes three factors into consideration. So all these three are based on the disease burden. The first one is the disease burden with the magnitude of the M spike. So if it's greater than 3 grams or per deciliter or less than 3 grams per deciliter. The second one is the plasma cell burden in the bone marrow biopsy. So whether it's greater than 10% plasma cells or not. The third one is the abnormal free light chain ratio, which also defines the magnitude of the clone. The patient has one risk factor. It's classified as low-risk smoldering myeloma. These patients typically have a median time to progression to symptomatic myeloma of 10 years. That means a 50% chance of converting it to 10 years. If there are two risk factors, these are considered as moderate risk. The median time to progression is 5 years. And if they have all three risk factors, the median time to progression is 1.9 years. So for those patients that are either moderate or high risk, I do recommend participation in the clinical trials and treating early. So,
can I ask about that? So the M spike, the plasma cell burden, and then what are you looking for in the free light chain ratio?
So whether it is abnormal or not. So all the clinical trials that were done previously have shown that an abnormality in this free light chain ratio defines the clone. So this free light chain assay is an assay that we've been using since the 2007 or 2008. What it does is it measures the kappa and lambda light chains that circulate unbound to the heavy chain in the serum.
Mm-hmm.
So a normal ratio is defined between 0.26 to 1.65, and in the presence of a clonal disorder, so in myeloma, there is excessive production of one specific type, like whatever the involved immunoglobulin is.
Mm-hmm.
So
like IgG or IgA or something.
This is the free light chain, free kappa or free lambda.
Oh,
so
the kappa.
The free kappa, since it's defined as a kappa by lambda ratio, if it's a kappa involved immunoglobulin, so the ratio is pushed to the right, and if it's a lambda, it's pushed to the left. So it's more about the magnitude of the clone. Okay. So coming to what this current criteria does not take into consideration is exactly what you pointed out. It does not take the biology of the disease or the genetics into consideration, which are currently being proposed to be included as in the high risk smoldering myeloma definitions. So that's how I would go with the diagnosis. I'd go with the risk stratification, and typically encourage patients who fall into moderate to high risk smoldering myeloma to participate in the trials with good mechanisms of action. And in regards to follow-up, like how often do I follow these patients, initially I would obtain the restaging labs to be done every few months, around 2 to 3 months for the first year, to confirm the stability of the protein, and then slowly extend the interval by every 4 to 6 months for the next year. And if the paraprotein has remained stable, not budging, so I eventually would do every 6 to 12 month follow-ups once clinical stability is established.
And it seems like there are a lot of new approaches in smoldering myeloma, because I think you're all looking at it and saying, why are we waiting to treat this disease if someone is high risk and someone has a very good indication that they will progress? Because like you said earlier, that it's kind of this continuum of progression.
Sure. So this is an area where I'm very much interested in and I strongly take pride in. One of the things that I've been working with is OncoPep. OncoPep is a therapeutic vaccine, which is it's a HLA-A2 restricted tetrapeptide. It's a tetrapeptide of 3 known antigens which are expressed in the malignant plasma cells. So the antigens are CD138, CS1, and XBP1. So the trial basically was started with this vaccine, which is the PVX410, with the objective to determine the tolerability as a single agent. That's when you're talking about a phase 1 trial, your primary endpoint is always the safety and tolerability. So what happened in this specific trial was adults with smoldering multiple myeloma who are considered moderate or high risk with more than 2 risk factors, as we spoke about from the Mayo Clinic stratification. And these patients, if they're HLA-A2 restricted, HLA-A2 positive, they were eligible to get onto this trial. So,
can I ask a question about that first? Why does
Sure.
someone need to be tested for their, so HLA testing is usually used when you're going to be, you're going to do an allo transplant and you have to see if someone's a match. Can you explain HLA just briefly and then explain why you need to be tested for that to participate in this clinical trial?
Sure. So HLA is also called the human leukocyte antigen. So in simple words, so just like how we have the blood groups, the white cells have this group called the HLA-A2. HLA, the human leukocyte antigen system. So this peptide is specifically made for the HLA-A2 patients, which are probably around 60% of the Caucasians and 40% of the African Americans.
Oh, I didn't know that. Okay, and then this peptide is targeting these three proteins, like the CS1, the CD38, and the XBP1. That's what it's targeting?
That is correct. So the XBP1 is all these three are antigens that are very commonly expressed in all the malignant plasma cells. So when you're talking about, anytime when you're talking about a cancer vaccine, it basically, I'll give you the idea of what a cancer vaccine is. It's based on the premise that the cancers have the ability to evade the immune surveillance, and the cancers develop as a result of the failure of mounting an effective immune response against the cancer cells.
Mm-hmm. So they're not attacking it, yeah.
Yeah. So by using a cancer vaccine at any time, you're retraining the immune system to recognize these cancer cells and trying to stop them from growing.
Mm-hmm.
So a therapeutic vaccine like the PVX-410 that targets the tumor antigens of CD138, CS1, XBP1 has the potential to stimulate the immune system to attack the myeloma cells and at the same time not interfering with the healthy cells. How do we...
Yeah, that's huge.
Yeah. So the goal is to elicit the tumor-specific immune response and induce a long-term durable remission.
Mm-hmm.
So about this specific vaccine, this was developed in at Dana-Farber's Cancer Institute by Nikhil Munshi's group. It was tested on the myeloma cells in vitro, where this peptide cocktail elicited an immune response to target the specific antigens on the myeloma cells. So moving forward in the phase 1 trial, as we just spoke about, what the goal of a phase 1 trial is to look at the safety and tolerability. The results were recently presented at the American Society of Hematology annual meeting in December of 2014. A total of 12 patients were enrolled. So in the first 3 patients on this trial, the low dose of 0.4 milligrams was administered, and once we'd seen the safety signal, the dose escalation was made to double the dose to 0.8 milligrams, and an additional 9 patients were enrolled. So how do we look for the immune monitoring? There's an assay called the LA-spot assay, and whether all the patients were obtaining an immunological response is what's measured. And these results were amazing in that all the 12 patients responded to at least one peptide at any time point.
So when you say they responded to one peptide, are you checking all 3, the CD138, CS1, and XBP1? So you're looking at all 3 or to see response or not? Or is it something else?
Like
okay.
In each patient, these 3 immune responses were measured. So the XBP1, as we talked about 2 peptides with XBP1. On the first one, which was the unspliced version, like it was seen on 9 of the 12 patients. In the spliced version, it was seen in 8 of the 12, and with the CD138, it was seen on 5 of 12. And the last one, the CS1, it was seen in 2 of the 9 patients, but I think at least 3 samples were not checked for logistic reasons. So every patient that was enrolled on the study had at least one peptide response, responded to at least one peptide at one time point.
Wow.
So currently, the trial has been expanded to a second arm. Again, this is a phase 1 where the patients are receiving the PVX-410 along with the adjuvant and lenalidomide, which is an immunomodulator to augment the immune response.
So now you finished the first, this is still in phase 1 trials though, or have you moved on to phase 2?
This is still in the phase 1 trial. The phase 1 trial was tested as a single agent first, then we went on to test the phase 1 trial in combination with lenalidomide.
Because lenalidomide was used, I know, by the Spanish group at first to try to prevent progression in smoldering patients, right? So now you're just combining the two?
So it's not only for that reason, it's more to augment the immune response. So the trial that you talked about was one of the trials that's worth talking. This was basically from the Spanish group that's called the Fatima group, where at one point I think they randomized all the smoldering patients to lenalidomide and dexamethasone versus observation. So the patients who were on the lenalidomide arm were given the same dose as we are giving at 25 milligrams on days 1 to 21 every 28 days, along with dexamethasone 40 milligram weekly. They gave it for 9 cycles, and then they stopped the dexamethasone and went on to lenalidomide at 10 milligrams as maintenance for another 2 years. So again, the primary endpoint for that trial, for the Fatima trial, was progression to symptomatic disease. The study met its endpoint, and the 3-year overall survival rate was much higher in the treatment group, with 94% of the patients alive at the 3-year mark for the lenalidomide and dex arm, and patients who were on observation, 80% were alive at the 3-year mark. So it was a good study with a positive endpoint. There were a lot of deficiencies in the studies in this particular study from what I believe. One of the things is there was no role for any MRI or PET CTs that was done on this particular study. So which means a patient could have symptomatic myeloma and still went on to the observation arm. So it is just that they have not been looked carefully for an occult lesion. So that is one of the main criticisms for this particular study. The second one is that also explains for the high mortality that is seen. Like at our institution, our 5-year survival rate in the myeloma patients is greater than 80%. And here, for a smoldering multiple myeloma patient, a 3-year survival of 80% in the observation arm is very, very less, in my opinion. And besides, there were some adverse events that were seen in at least 40% of the patients that were enrolled on the trial on the treatment arm, and these were more related to the dexamethasone. So there is a new trial from the ECOG, which is the Eastern Cooperative Group, using only lenalidomide versus observation, and they're continuing till the patient is progressing. So there is no early stopping, there is no fixed duration. It is given continuously.
And I think the exciting part about using a vaccine is that you're able to use something that doesn't affect the healthy cells, and And now if you're using lenalidomide with it, you can boost everything. So maybe you can explain, I guess in simple terms, how it goes about leveraging the immune system, and then maybe explain how it's given. Like, what are the steps? How often do you give the shots and things like that?
Sure. So at the 0.8 milligram dose, I'll go with the dosing and schedule first. What we're giving with the PVX, and I'll go with comparison with the normal vaccine. So the patients currently receive 0.8 milligrams of PVX for a total of 6 shots over a 10-week duration. The lenalidomide was given for 3 cycles. Each cycle is 28 days long, days 1 to 21 on and 1 week off. So lenalidomide is orally administered, and PVX is given as a shot. That is the schedule. In terms of the how it leverages the immune system, so the vaccines, the therapeutic vaccines, are very, very different than the preventative vaccines. I'll give you an example with any of these infectious vaccines that we talk about. So the traditional preventive vaccines are administered to prevent the disease. They're not used to treat an existing disease, unlike the therapeutic vaccine. So that's the main way, or the indication for a therapeutic vaccine, or the main difference. So there are certain challenges with the cancer vaccines since over a long period, and it's an ongoing challenge for many of the tumor immunologists, that the immune systems, the immune system finds difficulty in distinguishing the cancer cells from the normal cells, because the cancer cells also carry the normal self-antigens along with the tumor-associated antigens. And what the tumor also does is it sends these signals to suppress immune responses, and it evades the immune system. So all these are consistent challenges with any of these therapeutic vaccines, and or a period of time, and that was one of the main reasons why they have not made a huge progress until recently, where we are seeing all these responses.
Yeah, it seems like there's this big boom in cancer vaccines, and it's in myeloma, but it's elsewhere too. So that's really, really exciting.
Sure.
So patients go in for 6 shots over 10 weeks, you said?
That is correct.
Okay. And then what about? Say that again. Sorry.
Sorry about that. Each vaccine is 2 weeks apart, so it's given over a period of 10 weeks. Okay,
that makes sense. And then I know in smoldering myeloma, sometimes it might be a challenge to find results, because smoldering myeloma doesn't progress as fast, and so I know sometimes people have been hesitant to run smoldering myeloma trials because they think, oh gosh, the outcome is could be years before we see if this works or doesn't work. But it seems that if you choose the high-risk smoldering myeloma patients that are close to progressing or would be progressing regardless, then you can get study results within a reasonable time frame. Is that how it's set up, or what do you expect for your results? Because it seems like so far you've got really promising results.
Sure. So as you mentioned, like it's always a challenge to run a clinical trial among patients who have to be followed over a prolonged period of time. But what we're looking here is we're looking for the safety and the efficacy signal in the
Mm-hmm.
high-risk smoldering myeloma patients.
Mm-hmm.
So, which in the phase 1 trial, we were able to obtain that safety trial, and in the efficacy signal by the immune correlatives were already seen. So, in the future, it can be extended to other smoldering myeloma patients once it shows good efficacy results in further trials.
Mm-hmm.
So,
and do patients ever need booster shots after that one set of shots?
It's a great question. I think right now in this phase 1 trial, the trial is we're testing the safety of the combination of the PVX and lenalidomide,
Mm-hmm.
which we had seen, and in this current trial there is no plan for the booster dosing,
Mm-hmm.
but eventually, if the immune responses are fading over a period of time, it's worth considering booster shots.
Well, everything one step at a time, right? I mean, you have to decide if it's safe first, and then how much you give, and then does it work? And it looks like it's working, so that's very exciting.
Sure.
I have a question for you. If it's working in smoldering myeloma patients, would a trial like this be considered for patients who are, let's say they're MRD positive, but their disease doesn't seem to be progressing at all? I know patients in that group sometimes, or who are in remission and don't want progression or want to stay progression, kind of feel a little left out, that there aren't a lot of clinical trials open for them to do something that's preventative. Is this something that you think could be used for that in the future once it's been through all the testing, or is that just not a reasonable study to put together?
You're absolutely true. I think based on if I have to use in a symptomatic patient a vaccine, that's probably the right place to start. So I think at this point the vaccine is being considered in an adjuvant setting, in post-transplant setting with immune correlatives as the endpoints. I think you're absolutely right. That's a place where you had the lowest levels of disease burden, and there is a potential for the vaccine to show efficacy and good responses.
So is there a reason why vaccines, I've heard other people say vaccines, the cancer vaccines that are therapeutic versus preventative, should be used when there is a low tumor burden, like you just said, and not when there's a high tumor burden. Can you explain why that is? It just can't get it all, or it's just not strong enough, or?
It's probably I'll give you an example from an allogeneic transplant standpoint.
Mm-hmm.
So for the body to mount an immune response, it takes time.
Oh.
And in the meantime, you do not want your biology of the disease to take over, and the disease being so aggressive. So I think for the immune response to happen over a period of time, you need the disease to be controlled during the time, and which can happen only in a setting where you have the lowest level of disease.
Mhm. Okay. Well, that makes sense.
Does it make sense? Yeah.
Yeah, it does. It does make sense. And I didn't know how long when you say it takes time to mount an immune response. How long does that take usually?
It's probably it's over a period of weeks to months.
Oh.
And our assumption is like we do not, if the biology of the disease is bad, like we won't have that window for the immune response to take place. Right,
because your disease is out of control anyway, and you need something harder like a transplant or something like that to knock it down.
That is correct. Some other form of therapy.
Okay. Well, this sounds like a very exciting clinical trial. Is there anything that you would like to describe about the trial before I ask you about some of your other studies?
Sure. In terms of the tolerability of this trial, the vaccine is very well tolerated. Whatever the adverse events that we had seen as a single agent or in combination with the lenalidomide, the results of the vaccine in combination with the lenalidomide are not out yet, but as a single agent, what we had seen were all less than grade 2 and not serious. The more common adverse events occur within the first 2 days after the dose, and they had local reactions like chills, fatigue, and localized erythema. These are the more common reactions that could be expected from any vaccine.
Yeah, that's pretty typical of vaccines, right? Yeah. Okay, great. Well, it sounds like it's promising, and there's not a lot of downside to it. So I think it would be an exciting approach for smoldering patients.
That's true.
Now, I wanted to just spend a few minutes, and we have several caller questions that I want to be able to get to, but you have other studies that you're working on, and some I was not familiar with, and some I was. Is there anything in particular that you would like to share with us about other clinical trials that you're running?
So there's one phase 1 trial which that we have, which is very interesting in the sense like it's a P97 inhibitor it was in the symptomatic myeloma patients. P97 is considered a master control of the protein degradation pathways. So inhibiting this P97 would lead to inhibition of the protein degradation and polyubiquitin accumulation and subsequently the cancer cell death. So we have this is a phase 1 study. There are currently 2 cohorts that are completed. A cohort 1 with 3 patients with a lower dose, the second cohort with a much higher dose. All the 6 patients did very well, and we got a great safety signal, so we're going on with the cohort 3 at a higher dose. So that is one trial which is very promising.
And what's that one called? I have several numbers written down, and I don't know which one that might be.
It's a CB5083
okay.
CLC trial. There are others which I'm collaborating with City of Hope and Washington University. One of them is ixazomib with POM and DEX. This is again in refractory multiple myeloma patients, and ixazomib is a oral proteasome inhibitor. It's evaluated in combination with pomalidomide and dexamethasone, again in relapsed refractory myeloma patients. So based on this is a all oral regimen, and based on the available data, this combination definitely has a potential for an efficacy.
Okay, and they just released ixazomib just released some good results recently.
That is correct. Like the presentations at ASH 2014 were pretty impressive, and the main reason for this particular study is we know that there's a good synergy between an immunomodulator as well as a proteasome inhibitor, and this having an all oral therapy would prevent the visits and would have a good efficacious agent as a oral combination treatment. So that's what all of us would be looking for.
Well, that makes life much easier for myeloma patients not to have to be in the clinic for all the infusions, if possible. And if not, we still go. But it's better to have oral. Well, Dr. Nooka, I would like to open it up for caller questions, if that's okay with you. I know several people have questions. So my last question, you mentioned earlier that for smoldering patients, a lot of times you recommend clinical trials. Can you describe the importance of clinical trials for you and how it helps you in your research?
Sure. I think in my personal opinion, we cannot advance without clinical trials. Whatever the advances that have been done so far in myeloma are all because of the participation of patients in clinical trials. So I always remember one great saying from Judah Folkman, who talked at one point that if humans were mice, we could have cured cancer. So what is happening outside the body is entirely different than what happens in vivo. So what appears to be a promise in the cell lines and the xenograft models, that compound may have no effect, and it's the vice versa. What shows a moderate activity may turn out to be extremely effective. So it's essential for all of us to recognize that without a clinical trial with human participation, we will never be able to make any progress that we have made for myeloma so far. I have a strong respect for the patients and families that have participated in the clinical trials, and I strongly urge patients to consider clinical trials that would eventually give the best outcomes.
Well, I agree, and with a disease that you've extended life, but we still don't have a cure, so we need to move forward. So I'm in agreement there. All right, well, let me open it up for our first caller question. So caller at phone number 465-8689, go ahead with your question.
Yeah, my name is Linda, and my question is this: a definition of what you consider to be smoldering. My doctor now tells me I return to a smoldering state, but I am a post-transplant. I also did the evolution clinical trial. In 2008, I entered active treatment, but in 1991, the Mayo Clinic missed my diagnosis. Clearly, all the components were there, which is clearly recognized by my doctor. And so I was smoldering for at least 19 years and possibly way more than that, because I've had blood count problems since 1976. Following an injection which I received way back when they thought I had a brain tumor of a mercury component, which I believe had a great demise for me. But I really have trouble with this number of smoldering. I mean, is there a place for a vaccine for somebody who now has re-entered a smoldering state after treatment?
So thanks for the question. I don't think we have any trials open for exactly suiting your clinical criteria for a smoldering state. So I'll clarify for the other listeners what Linda means by a smoldering state after she receives a transplant. So it's not uncommon for us to measure a small amount of protein after they finish their induction treatment, a consolidation treatment, and still you're seeing a small amount of paraprotein of around 1 gram or less than that. And it shows a stability over a period of time. Say, for example, after 2 years, 3 years, it is not moving any longer, you're not on any treatment. It is not uncommon to call it that you had gone to a smoldering state where you were before all this diagnosis has happened. So that is what Linda means by going to a smoldering state. So in the absence of the stability having seen the stability over 19 years, if it's not changing anything, I would not do anything different than what you're doing now with observation.
Well, the 19 years was 19 years ago. Well, it was 19 years that the Mayo Clinic did not catch the diagnosis, even though it was all clearly there. All the factors were there, clearly recognized by my oncologist. But in 2008, I entered active treatment. But I still have a question. If I return because of my M spike protein reaches like 0.8, then why would it be that I could spend 19, 20 years at 1.62, which is double that amount, and live a normal, healthy life other than some strange-looking blood counts? Why would you jump back into treatment?
So I'm sorry, I did not understand the question. Like if you have entered the state where it is smoldering, I would not recommend any treatment at this point, unless it's showing.
I've been off treatment for about 2 or 3 years because I've been doing fine. But if I go back to a 0.8, the statistics out there show that I'm supposed to go back into treatment. But my question was, if following the misdiagnosis by the Mayo Clinic, where I was at 1.62, which is double the amount of the 0.8 that would put me back into treatment, why do we look at numbers like that and say, okay, go back into treatment? I mean, I spent 19 years of, having a good life.
Sure. Your question basically points to the same thing that we talked about. It's not just the magnitude or the size of the paraprotein that should decide on the treatment options. It's the biology of the disease. How bad is the clone that we're dealing with? Is it a dormant clone that doesn't need to be monitored, like if it's staying stable? So compared to something else which is extremely aggressive, where I would recommend immediate treatment. At this point, I think staying off treatment and being on observation with the stability that you're seeing is what we recommend.
Yeah, I've never had any bone involvement.
That's good.
Yeah. So do you see a vaccine coming along for people like us who would like to stamp out this thing once and for all?
Eventually, yes. Like if it's showing the same responses that we are seeing, and if it is confirmed with the lenalidomide to augment the responses, it would be nice. And I think talking about drug development it's a tedious process. It takes a long time for it to be FDA approved. It probably, on an average, each drug takes 8 years from a phase 1 to its approval.
8 years from now.
Yeah, it's a long process.
This vaccine, but a typical drug. So who knows? Like we might see some great activity, and it could go for an expedited approval, and probably would be available much sooner.
Okay, thanks.
Thank you. And I second your idea of the clinical trials, and just like to state that I did the evolution clinical trial and it knocked all those numbers down. So thank you for your work.
Congratulations, Linda.
Thank you very much for your question. Okay, we'll take another caller at 727-5303. Go ahead with your question.
Yes, doctor. Thank you for an excellent presentation. I had a question about your time to progression for the 3 criteria, especially the Mayo Clinic, on smoldering. I'm a kappa light chain guy. I've been smoldering for a few years, a free light chain issue that we watch. But you mentioned the 3 criteria: the magnitude of the M spike, the plasma cell burden, and the free light chain. For those of us that are worried about our free light chain, once it goes over 100, which mine has recently, and we're doing a bone marrow biopsy, but let's say it goes to 200, is that indicative of potentially imminent renal failure and the need to jump into treatment? Or if I followed your 1 risk, 2 risk, 3 risk category, that would still say if you only have one of those 3, you could potentially still smolder for quite a while. So how difficult is the renal environment, so to speak, for the high light chain people?
So this is a great question. So basically, in the previous trials, in the previous IMWG working group, International Myeloma Working Group criteria, they did not include this 100 milligrams as a criteria. It was recently included. So the way that I look at it is the stability of this free light chains if your free light chains are 150, if the free light chain ratio is 150, you had it for 7 years, that is way different than somebody who had a ratio of 50 last month and 150 this month.
Mm-hmm.
So that's where a clinical decision and following the history over a period of time makes a huge impact on the decision making. So why is the free light chain ratio? Why was it included? Like, it was based on a lot of trials showing that the free light chain ratio of at least 100 is a predictor for progression in smoldering multiple myeloma. So that is one of the reasons it was shown by the Greek group. It was shown by multiple other groups, basically, that free light chain ratio of at least 100 had almost progressed in a year and a half. So that's where all this comes from. But because you were not a smoldering myeloma in September, in October the new guidelines came. Should we change everything and should you get started on treatment? I don't think so. You probably need to be followed for some more time and see where your protein is progressing. If it is not, if it has remained stable, I would continue to watch.
I understand. Thank you.
Sure.
Okay. Thanks so much for your question. Okay, we have two more callers. One at 992-4568. Go ahead with your question.
Hi, Jenny. This is Gary Peterson. How are you?
Hi, Gary.
Yes, doctor, excellent presentation so far, and I think that I had recently interviewed Dr. Gobriel from Dana-Farber, and one of the things that she said was that it's not really watch and wait, it's watch and worry, and that's why she was working so hard to come up with a method. But yours sounds very interesting as well, which is to have a vaccine along with Revlimid, which is what the Spanish group used. But my question to you is this. There's 400,000 people who are high risk, or not high risk, are smoldering, according to your definition. And one question, would 15% of those smoldering patients be considered high risk? Is it the same percentage of patients who are smoldering that are high risk as are symptomatic and are high risk?
So to address your question, so basically the abnormal free light chain ratio is what was considered as one of the criteria for the smoldering myeloma. So if you look at the numbers, like around in the smoldering myeloma group, approximately 60 to 70% of them have abnormal free light chains. But the definition of an abnormal free light chain, which is in the Mayo Clinic, is considered as anything above the ratio above 8 or less than 0.125. So to fit that criteria, how many of these, what percentage among these 400 patients would be, and that's difficult to estimate, but it would not be greater than 30%. That's my estimate. Does it answer your question, Gary?
That would fit into the high-risk category, would be 30%. So 30% of 400,000, that would be 120,000, right? Which is a lot of people. Now my next question, which kind of follows that, would be at your facility, and that's only your facility, of all your patients, what percentage are smoldering?
Around 15% are smoldering, which also explains for the referral bias for one reason, that if not all, mine is a tertiary center, so it typically, if somebody is smoldering, they might come one time and they go back to the treating physician for follow-up. What we do is give an opinion. So that probably might explain for why there could be lesser number of smoldering patients that are seen. But when there's
what What I'm trying to kind of understand to some degree, and it's something that Jenny said earlier, and which kind of hit home for me, and that is, she said that that of the smoldering patients that are out there, most of them have no clue that they're smoldering, given what you just said. Now, if, say you're wrong by 100%, right, and it's really 30% of your patients. Well, 25,000 patients a year, you said, are diagnosed, correct? And so 30% of that would be about 7,500. So 7,500 of what did we say? It was 30% of 120 or 120,000. So we're not catching a whole heck of a lot of these folks that are going to turn into active myeloma patients in 2 years. And how do we change that math?
Sure. I think what you asked is a question that I always encourage and always want more screening about. So it is, as I mentioned, it's a continuum process. It has to go from MGUS to the smoldering state to myeloma. Like every single person goes through that. The rate at which they go differs. So it depends on the primary initiating events. It depends on the secondary hits at what point it takes place. So I would not differentiate how many patients were diagnosed with de novo myeloma versus diagnosed from a symptomatic myeloma. Every patient develops from a symptomatic myeloma, as there is enough data to show that from the NIH. So in the past, what they did was they had around 76,000 patients in NIH who gave monthly blood samples. I think it's 3 monthly blood samples over a period of time for 10 years or so. And when they started looking back at how many patients got myeloma, they found around 71 patients had myeloma among that group. So they went back they had the blood samples for the last 10 years. So they went back through the blood samples of all these 70 patients and found that majority of the patients had this diagnosed like almost 10 years ago. 80% of them were able to show that protein lingering. So it is not something that happens over a month or over a year. It has been going on for a period of time. So the point I'm bringing up from this discussion is every myeloma is preceded by a smoldering myeloma is preceded by an MGUS. So how do we identify all these patients, all these 300 or 400,000 patients existing that have a potential for converting to symptomatic myeloma is the biggest question. So it comes with some caveats, like if you find a lot of MGUS patients, it is only giving them worry because they're not. All you're saying is a small protein, and that statistically will not have a chance of converting to symptomatic myeloma in their lifetime, and they're living with this constant fear of when. So that is the biggest caveat that comes along when we're trying to aggressively screen for these smoldering myeloma patients.
Mm-hmm. It's a catch-22, seems like.
Yeah, but the same thing would hold true with breast cancer and or colon cancer, lung cancer, or anything else, is that you go in, you get a mammogram, you find out you have a tumor, and in breast cancer, if, like, for example, my wife had DCIS, well, it's removed, and there's 100% chance in 5 years she's going to be alive.
Sure.
Now, for some reason, you don't do that test, you don't get a mammogram, and you find it when it's a large malignant and one that has metastasized, you have a 22% chance of living 5 years. And I think what you're saying is that if you attack it early, like all other cancers, and why wouldn't it be that way, that you have a high probability of success because the clones haven't developed, and it's resistant to drugs haven't developed, and all those things, those same reasons that they have such success with colon and breast cancer could happen with our cancer. But our issue is we got to find it first, and people will deal with the 1% chance if they got MGUS. But the fact that if in fact they get screened. So I guess my point is that we should be going for mass screening because the result of what you're doing are so, are earth-shattering for the potential of success for myeloma, for smoldering patients who would progress. So that would be my point.
Sure, I think I completely agree with that. So going back to your question of why we screen for the colon cancer or the breast cancer, yes, we have a tool to address to it. There is a surgical tool, and probably everybody gets when somebody gets diagnosed with BCIS, you go and treat it with surgery. Now at this point, as of today, even if I'm diagnosing all these patients who fall into the smoldering myeloma, we are not doing anything outside the context of a clinical trial. So that would be the biggest difference between what's happening with the breast cancer and what's happening with myeloma. Eventually, if there is a vaccine, or if we find a tool that would address the plasma cell dyscrasia from progressing to symptomatic myeloma, yes, I would strongly encourage everybody to go with a mass screening and diagnose all these patients and do the necessary to hold off on the transformation.
Mm-hmm. Well, thank you, Doctor, so much. I think you are on your way, as is Dr. Gobriel. That you guys are, you're at the tip of the spear as far as I'm concerned.
Thanks very much.
Thanks for your question, Gary. Dr. Nooka, do you have time for one more short question?
Sure.
Okay. Our next caller, 983-6757. Go ahead with your question.
Yeah, hi. Good afternoon, Dr. Nooka. My name is Dana Holmes, and I'm a smoldering multiple myeloma patient. And I'm actually sitting here, and I'm astounded by the numbers that you're sharing about the potential smoldering multiple myeloma patients, 400,000. I'm sitting here dumbfounded because I have a Facebook group for smoldering multiple myeloma patients, and we have a tiny little part of that 400,000. We're about 250 members strong, so I'm really just astounded by that. And I just wanted to make an additional point, I guess carrying through what Gary had just said. I understand the caveats with mass screening, but I'm sitting here thinking that not providing screening would prevent many of these smoldering patients who don't know they're smoldering from actually engaging in some of these early clinical smoldering trials. So I just really wanted to make that point. And then I do have a few questions for you, please. You did explain that therapeutic vaccines are very different from preventative vaccines. And I believe in multiple myeloma patients and likely smoldering patients, we have impaired responses to vaccines. Just in general, flu, pneumonia, the pneumonia vaccine. As we begin to lose our immune responses to childhood diseases and vaccines just due to the natural aging process, and I would imagine with myeloma, this is an added assault to this process. So would that in of itself be the case with this peptide vaccine? I'm going back to your PVX vaccine. Would the response that we make be limited as a result of this?
That's a great question. I don't think anybody knows the answer to this. Like we make a general statement that you're in myeloma patients the responses are limited, but again that's a general statement. It is not backed up by a huge amount of data. So coming back to our data, we had seen immune responses in at least one peptide in every single patient that we have treated and with a single agent. So by adding Revlimid, we probably would be augmenting the same immune response, and we probably could find most of them. So that's the hope.
Oh, I see. Okay. So the Revlimid is to augment the immune response. Does it also knock the disease back a bit?
That is correct.
So it has like a double duty factor to that.
That is correct.
Great. And I realize the inclusion criteria for the PVX trial is irrespective of cytogenetics, and it does include the Mayo guidelines, the free light chain ratio outside of the normal range of 0.26 to 1.65. But I find from my own monitoring that my free light chain ratio is prone to bounce around from test cycle to test cycle. So should the trend of the ratio be important to consider to participate in this trial, or is any one given test result enough to meet the inclusion criteria?
It should be the trend. The more, as with any clinical trials, it's more the screening criteria that makes the difference. So if, for example, if the involved free light chain involved, if it's kappa, if the involved is 30 and the free lambda is 1, at one point the ratio is 30.
Right.
And at the second time, if you do it with another machine, if it comes out to be 10, the ratio is 3. It does not mean that you have an abnormal free light chain ratio. It is a problem with the testing. So unfortunately, with repeated testings, you probably will know where exactly you fall into. And if you have an abnormal free light chain ratio and have a big amount of paraprotein and have plasma cells greater than 10%, you possibly might, if you're fitting 2 of 3 criteria, you will qualify for the trial.
Okay. And are patient cytogenetics still tested for research purposes to determine if this can be effective for all disease subtypes? I mean, I know that it's probably not shared with the patient, but are you guys collecting that information?
Yes, we collect the patient cytogenetic information on every patient, and we collect them for a research purpose. We do RNA sequencing on all the new patients and longitudinal testings on all the patients that relapse.
Is the information shared with the patient from the trial, from this research?
From this research, we have not done on all the samples, and if we have the problem at this point is there are so many mutations that we are seeing. We didn't know which one is the causative mutation, which one is the passenger mutation. So it is very difficult with the data mining with all these sequencing tests. But once we find some information that will be useful, we'd be happy to share.
Are there any plans to modify the vaccine so those without that specific HLA typing can participate?
Yes, ma'am. That's what's currently being worked on.
Very good. Oh, that's very good to hear.
That'd be great.
Yeah. How long will the patients be followed for, and how? Is it just the ELISA testing for continued immune response, or are there other diagnostics being used?
Currently, it's the ELISpot assay that's being used, and typically they're followed every 3 months. The assays are done while they're receiving the vaccine, but the immunological studies are done every 3 months.
So it'll be really long term until they progress, if that's the case, right?
So
that's the plan.
The patients are following up with us, so we continue to get the data. So we will have the data until the study is closed.
Wonderful. That's a wonderful approach. Would short-term Revlimid use exclude any of us from future trials, many of which have treatment-naive criteria? Is that something that we need to be concerned about?
Sure. That's a great question. So this came up in the discussion, and we've made it very clear that they should not exclude anybody in the future for any clinical trials at the time of the progression.
Wonderful. Dr. Nooka, thank you so very much for your time. I appreciate you taking all of my questions, and
sure.
Very best luck to you. We do share the trial information within our smoldering group, we are all keeping our fingers crossed for something like this to work for us. So thank you.
Sure. You have a great afternoon.
Oh, Dr. Nooka, thank you so much. Thank you so much, everyone, for your excellent questions. And Dr. Nooka, thank you so much for joining us today. You gave an excellent description for us that was wonderful about the criteria for smoldering myeloma, probably the most thorough I've heard to date. So, and the vaccine sounds very, very exciting.
Thanks, Jennifer. Thanks for having me on the show.
Well, thank you so much for joining us today. We appreciate all you do for all myeloma patients. Thank you for listening to another episode of Innovation in Myeloma. Join us for our next Myeloma Crowd Radio interview as we learn more about how we as patients can help drive to a cure by joining clinical trials.
Judy was boring.
Hello.
Then Judy discovered ChumbaCasino.com.
It's my little escape.
Now Judy's the life of the party.
Oh, baby, mama's bringing home the bacon.
Whoa, take it easy, Judy. The Chumba life is for everybody. So go to ChumbaCasino.com and play over 100 casino-style games. Join today and play for free for your chance to redeem some serious prizes. ChumbaCasino.com. No purchase necessary. Void where prohibited by law. 18+ terms and conditions apply. See website for details.